Yes. Yes.
Okay, good morning, everybody. Welcome to the staff meeting of Sedgwick County Commission and Sedgwick County staff.
There you go.
Try that again. All right. Good morning, everybody. Welcome to the October 6th Sedgwick County Commission staff meeting that we do pretty regularly on Tuesdays. So it is, again, October 6th, and with that, we have an item that we wanted to discuss related to staff. So I'll turn this over to the county, to the manager, Tom Stoltz.
Chairman, and good morning, Commissioners. Several months ago, Commissioner Howell had some questions about EMS data and service and some staffing challenges that they've had with EMS. And Dr. Gallagher has worked up some numbers. I thought it might be just more appropriate to present it to the staff meeting. It's been a little over a year ago now that we did the reorganization. Dr. Gallagher took over EMS, and so I thought it might be appropriate, since it's been a year, just to have a kind of an overview of what's happening, some of the changes that they have instilled, and some of the challenges that they're facing today in the time of COVID. So with that, Chairman, with your permission, we'll have Dr. Gallagher give a quick presentation here.
Okay. Good morning, Dr. Gallagher. Welcome to the meeting.
Good morning.
Thanks for having me, as always. So I'm John Gallagher. I'm the Director and Medical Director of Sedgwick County EMS. And as Tom pointed out, was asked to put together an overview of the things that have happened, the progress has been made, the troubles that we've encountered, essentially a one-year update, if you will. So it seems like 100 years ago, but it was actually last summer. The group decided to combine the old department of the Office of the Medical Director and the Department of EMS into a single entity. And since that time, we've been operating as a single group. So the first thing that we did, as any new leadership group would be to perform a self-assessment. And we did that through several different ways. But the most potent and important one was by hearing the voice of our people. So we met with our people. We actually took the executive team out on tour many days in a row, meeting with the frontline staff at the posts in very, very small meetings. Two crewmen with us, with no agenda, no specific questions, just the opportunity to talk and hear their voice and understand what their perspective was on how the department had run in the past, what they saw potential for the future, and really just to be kind of employee-centric in our approach to this. We heard very consistent messaging. The first 10 things on everyone's list was pay and compensation. When we got them to move on past that, they also had major concerns about training. Historically, the department had delivered almost no training. Staffing and turnover was troublesome to them. They had a difficult time with their own peers coming in and moving on quickly, and having a general lack of staffing, so both staffing and turnover. Several of them had some very real and very concerning safety concerns. Some of them were related to equipment issues. And from a decision-making standpoint, we had a group that felt like their autonomy was being restricted, or that they had the ability to make more independent decisions than what the system had historically allowed. From an organizational structure standpoint, there was frustration that at the time the critical care program was only available 12 hours a day and only during daylight hours, and that just didn't do any service for our nighttime operations. And then, of course, the reason for bringing the whole thing together was to improve the coordination between the clinical oversight and operations. So this voice of the people became the focus of what we decided to attack in the early projects that we took on. So in no particular order, we brought together the two departments into a combined design. So the previous was two departments, and now it is a single. And we're very proud that, with the exception of our new medical director who joined us from Florida, 100% of the promotions and reorganization happened internally with our existing staff. So this truly is a combined design from the people who had been doing it previously. It's roughly divided into an administrative branch, an operations branch, and a clinical oversight branch. And from that new route, we grew the rest of the tree into all 244 personnel that encompass our full-time staff, part-time staff, billing staff, logistics personnel, and everybody who flies the flag of EMS. Next, we tackled training. This was something that was near and dear to the hearts of the people, not only because they have a desire to provide excellent patient care, but because they have state mandates to get this training in order to maintain their EMT and paramedic licenses. So within the clinical branch under Dr. Pereira, we re-envisioned the clinical practice manager into a professional development manager and put under him 5 additional personnel, one that to be a coordinator for all of the training, and then 4 trainers from within our ranks who were known by our people and trusted by our people as excellent clinicians to pick up the baton of training and start putting out training hours. And they have been unbelievably successful. These are all of the categories of things that they have been able to put out. And so far this year, since they started in the spring, they've put out over 1,600 hours of clinical training. And that's just a clinical training. This doesn't count any of the required issues, bloodborne pathogens or HIPAA training or operational type things. This is just medical care training that's been delivered by this group. So a huge shout out to these guys. They're not surprisingly an animated group who have volunteered to spend their time in front of the cameras teaching their peers. All right, the third thing that we needed to address was the issue of frontline supervisors and the critical care. Like I said before, critical care was only available at the time during daylight hours, leaving half of the clock uncovered. So in the old model, we had a very fractured design. There was a day shift and a night shift with another shift sort of stuck in the middle. The supervisors were divided and there was only the one critical care medic. So we reorganized those personnel and put them into dedicated shifts. So you can see it's a lot cleaner in the new design. And our personnel know exactly who their reporting structure is and who they're responsible to, as well as adding the rebranded advanced practice paramedic to each shift, so that not only do we have 24-hour coverage, but we now have overlap coverage during the busiest part of the day. Big wins there. We turned our attention to equipment, and fortunately in 2020 we have been able to take on an amazing pile of new and updated modern equipment. We had a whole new fleet of our LifePak monitors. Those are the cardiac monitors that monitor vitals and cardiac rhythms, as well as provide shocks for patients in cardiac arrest. We received a retrofit for the entire fleet of power load cots. This is an automatic lift system that we'll talk more about under the safety section. We got new CPR devices. That's the mechanical chest compression devices. We also got some real high-tech IV medication pumps. This is for use of medications that are so delicate that even use through a syringe isn't sufficiently accurate. They need to be done by a computerized pump to make sure that the patient gets the correct doses of medications. And then, of course, in the era of COVID, we added thermometers and ventilators to our stockpile. So that's a picture of the new cots that we took delivery on. So safety came up in many of the conversations with the frontline staff. This obviously has a direct impact on them, and failure to consider the safety issues of our people would be a major failure. So substantial work went into figuring out what best ways to approach provider safety. And we did most of this through our employee advisory committee. So we have a group that meets monthly that's comprised of frontline staff from all of our different shifts, and essentially comes together as a council of personnel that can give us advice on, again, the voice of the people to what they need. So we had 3 big projects. The power load cots is the motorized stretcher, which mechanically, hydraulically loads the patient into the back of the ambulance, which not only provides stability for the patient, but reduces the need for lifting of the patient. So we can now have even very heavy patients. These hold up to 700 pounds, and the crew can lift them with the push of a button instead of the old way of using their backs. So major development there. We also moved our equipment bags from an old luggage-style plastic suitcase which put all of the weight over on one side out on the lever arm of the shoulder and were causing shoulder injuries. We've moved those into a high visibility backpack style, which allows them to distribute the weight of the equipment over both shoulders in a far more ergonomic way. And we believe that that will not only improve their comfort, but also decrease employee injuries. And then the third project was the crew had interest in moving to a more comfortable duty wear uniform, a polo type uniform, and away from the old button-up military style uniform. So we have transitioned the frontline staff to a high visibility ANSI 2 certified high visibility uniform, and the office staff to the white that I'm wearing today. So you will see more of these uniforms as we get them throughout the staff. So I would be remiss not to once again thank the Employee Advisory Committee for their work on this. These were truly employee-driven projects. All right, so we had addressed the critical care availability. We addressed the coordination between clinical and operations. We made incredible progress in training. We updated the equipment, and we have tackled the first of several safety initiatives. But there's still some things that we're working on. In the clinical branch, we've decided to tackle the issues of autonomy. So no one believes better than we do that our people are smart, well-trained, and have the ability to make individualized decisions. But the way of EMS has always been a very prescriptive, list-based set of rules or protocols, as they are known, that tell them exactly what to do and make a febrile attempt at outlining every possible situation that they might run into, which is obviously a fool's errand. So we have envisioned with our new deputy medical director this more centralized, patient-centric model of designing our thinking. Within the center, that core duty to provide a safe, competent, and compassionate care, without necessarily being prescriptive as to how that's done. So this is still in the works, but this is an excerpt from our pain management. And each of the protocols is now has a section called considerations, which attempts to guide the paramedics and EMTs to the areas where decision-making should occur. Rather than giving them a list of here's what you do and you better do it, it's a here's the things that you should think about as you make your decision. And it's written in a very intentional way to empower them to do so, talking about things like judgment, caution should be exercised, appropriate to individual circumstances, and things like consideration or may warrant. These are written in a very protective way so that they can make these individualized decisions for the patients. We've got some things that we're going to need help with, though. We're not going to be able to accomplish the list that our people gave us within just the department. Unfortunately, we've identified some fairly major disparities in pay parity across the public safety divisions. At the urging of our people, we looked into what the pay differences were between ourselves and EMS and our two main fire departments, City of Wichita and Sedgwick County District 1. And unfortunately, we found that in every single rank, both at the minimum, the midpoint, and the maximum, the EMS personnel are in last place for compensation. So this is going to be a challenge, and this is something we won't be able to manage just at the department level. This past spring, we did work with our partners in finance and budget, and this is an excerpt from a decision package that aims to bring us to pay parity with the fire department over a 5-year plan. And unfortunately, like so many other decision packages with the economy what it is and COVID being what it is, this was not able to move forward as a decision package, but we are excited to have done the groundwork on this, and I think we will be moving it forward when the time is right. So we've got this one in the queue ready to roll. And then the toughest challenge so far has been staffing. This is a tough time to be in EMS. They're one of the people that are asked to do some of the most dangerous and anxiety-provoking work that we have in the city right now. And we've seen a lot of separations. So my new team has been at this for a year, but when we look back over the last 5 years, we can see that back in 2016, we started to see a progressively increasing slope of our graph of separations. So we can speculate as to what started causing that so long ago, but we are seeing it continue, and the suspicion is that it is only worsened by the circumstances that they're operating under right now. Unfortunately, it's a dramatic percentage of these are paramedics. We are seeing them move to other jobs, competing EMS agencies, as well as competing healthcare industries like the emergency departments or the freestanding healthcare centers. These facilities are offering jobs with less risk, less exposure, and greater pay, and our experienced decision makers are tempted away from us to these different jobs, and it's very difficult to retain them. So unfortunately, we have that trend to deal with. This is a picture of the frontline staff. So these are the personnel, the FTEs that actually staff the ambulances. And the red boxes represent FTEs that are open, empty slots, places where we could hire someone. But all of the other colors represent people who are on the books but can't work for various reasons. They're out for FMLA or injuries or military deployment, even COVID quarantines. So it's a mixed picture between having staffing difficulties because of open spots and having positions that simply can't come to work for the various other reasons. So when we look at our staffing situation, we fortunately still are at about 78% staffed. Those open positions total up to 18, which is 13% of the staff, and then the remainders come from the 4 people that we have out for COVID and 9 additional people that are out for other reasons. So if we just look at the 8 unfilled positions, you would calculate a 13% vacancy rate. But from an operations standpoint, it is far more appropriate to consider everyone who can't come to work, which gives us an effective vacancy rate of 22%. So the ins and outs of the department, we've had an AMT who separated, one EMT who separated, and unfortunately 30 paramedics who have separated. We balanced that partially by bringing in 11 EMTs, 8 paramedics, and transitioned one of our part-time paramedics to full-time, but we still ended up down 12 so far year to date. And that trend line, that bar graph that is climbing, continues to climb. So far we are down 8.6 of our total full-time field staff. Response times. So this is a graph of our overall response times, and it includes all 911 calls. And you might be tempted to say that this is a climb in our response times due to staffing. And while staffing might be a portion of this, it is far more likely to be the result of the efforts that we have had to decrease the amount of lights and siren use by the frontline staff, which by design increases response times. So rather than looking at an overall 911 call type for response time changes, it's better to look at the lights and siren calls. So this excludes the non-emergency things where they follow all of the traffic laws, including red lights and stop signs. And this is the calls that are only used with lights and siren. And while it has maybe crept up a few seconds, nothing that would be considered clinically significant. Our lights and siren response time remains flat. We do have some contractual performance requirements, first with the City of Wichita, and while we haven't had a perfect run, we have maintained within compliance and are fully meeting the requirements of that contract. We also have contractual performance requirements with both hospital systems, the Ascension system and the HCA system, and both of those are fully meeting their requirements as well, and we remain in compliance with our contractual agreements to the hospital systems. So ambulance service delivery is where we end up. This is what actually affects the public. So we exist on this balance of having all of our trucks available versus all of our trucks busy. And where we are along this spectrum changes the features of which the system is operating at. So if we were to maintain a system that had all of our ambulances available, we would likely achieve shorter response times. There'd be more trucks available. It would absolutely cost us more because those trucks that are available aren't able to generate billing. They're not running calls, they're not providing service, and they're not generating revenue. The employees would have lots of free time. That's good for morale, and we can accomplish several other things. And of course, it's lower risk. The fewer patients that you see, the less exposure that you have. And then on the other end of it, it's exactly the opposite. As we get busier and busier, response times creep up. Our costs actually improve due to our income and revenue. Employee fatigue climbs and our risk starts to go up. So this is what ambulance demand looks like by hour of the day. So midnight is on the far left, and it progresses through noon in the middle. And you can see that in the wee hours of the night, we do have fewer requests for ambulances, and it peaks out at about 3 or 4 o'clock in the afternoon. The orange line is how many ambulances we target to staff. This is what our staffing model is built to, and the number of FTEs that were assigned in the staffing model. So the available ambulances is simply the difference. All of the ones that are running calls aren't available, and all of the others up to that line are available. So during that slow spot at night, we've got the most trucks available, and during the peak in the afternoon, we have the least trucks available. Typically, we are somewhere in the neighborhood of 5 to 8. Now, this is an average of averages, and of course, it fluctuates across this greatly, but at any given time, the probabilities are that within Sedgwick County, we will have somewhere between 5 and 8 ambulances available. If we ever get to the point where there are no calls running in the system during the daytime, we would get up to about 20, and we would have a target of about 13 at night. And then at the other end, if we ever get down to 0 units available, we call it a status 0 event. That would be that there's no available ambulance to take the next 911 call. Here's what our ambulance uptime looks like. So when we don't have adequate staff coming to work on any given shift, we do have to shut down ambulances. We can't staff them if nobody's there to be in the seat. And our supervisors will make real-time decisions as to which ambulances to shut down based on the what they have available to them for that given shift. So, for example, you would see that Medic 26 is one of the ambulances that gets preferentially shut down. And that's a wise strategic move by our supervisors, because that's one of our ambulances that has the most overlap with other trucks. And so having that one off the board has the least impact to our service area. So that's a wise move to pick that one on a frequent basis. But you can see that it does affect most of the ambulances at some point throughout the year. So the effect that this has is, if we go back to this slide, any time that we don't have a pair to put out on an ambulance, that orange line drops by 1. There's just 1 less truck available to the system. But what doesn't happen is the blue line doesn't move. We still expect the same amount of call volume. So what happens is the gap is narrower. We have fewer available ambulances to take that next call, and that increases the likelihood of having a status 0 event. If we ever get to the point where that orange line falls so low that it touches the blue line, that is a prediction that we will run out of ambulances. So people have oftentimes asked me this question. You may have been asked this question of, well, how many ambulances do you have? Well, it sort of depends on what you mean. Because if you're asking about my fleet, I have 31 ambulances. And that might be what you're asking. If you're asking me about our fleet costs, our replacement, adding equipment to things, all of the things that we might do pertaining to vehicles, say we needed to replace all of the radios, the number of how many ambulances we have is 31. That's the right question to ask. If you wanted to talk about staffing, well, during the daytime, we try to get to 20. Our staffing model, when full, gets us up to 20 ambulances. At night, though, it's 13. If you wanted to know how many trucks are actually available to the city, you would have to know not just how many do we try to staff, but how many do we actually staff. And that would tell you that during the day it's about 18, and at night it's about 11. And if you wanted to know how many were available for the next 911 call, it would be what we talked about in the previous slide of somewhere in the neighborhood of 5 to 8. So it would be categorically wrong for when somebody says how many ambulances are usually available to give them the daytime staffing number of 20. That would misrepresent the situation. This is going to become progressively difficult as our call volume rises. It would be hard for me to envision a more reliable trend line than this. This is our call volume over the last 30 years. So if anybody wants to place bets on where we're headed over the next couple of years, I think we have a pretty good idea of what this graph is going to do. And all that's going to do for our frontline staff is raise that blue line. So if we don't raise the orange line at the same time, the gap is going to continue to narrow as the call volume increases. Plus, we haven't talked at all up till this point about geographics. We've simply talked about how many trucks are available and what's left over in the system. But our calls occur in a predictable geographic measure. And I think each of you have been faced with considering the posts and the position of our ambulances, but there are far fewer people who've considered what do you do with this heat map if you only have 6 available ambulances. The location of our beautiful posts becomes a lot less important when you're down to only 5 or 6 trucks and you still have the same heat map to deal with. So clearly, this is a very complex interplay between art and science. We have lots of math and data that drives our decision making, but in the end, it comes down to the skill of our frontline supervisors to play the game and to have the pieces in the right place so that they can accomplish the moves that our patients need. All right, so last but not least, the bottom line. I couldn't come before you and not talk about our dollars and cents. Fortunately, there's some good news from our billing people. We are just over $500,000 ahead of our year-to-date target for revenues from billing, which is 4.2% of our total target. And just a little factoid for you there, the average collection per transport is just shy of $320 for a given ambulance run. That's our 2019 yearly average. This is a comparison of the per capita tax subsidy that we have. This data was last done in 2016, so the numbers will have changed a little, although I suspect the relationships will not. And you will notice that in comparison to our next door neighbors in Johnston County, we run at about a quarter of the cost, or said in another way, theirs is 4 times as costly as what we have on a per capita basis. So despite the troubles that we have, we are a hell of a bargain in comparison to other EMS systems and what they cost. Overtime has come up several times in questions, and while it continues to be an expensive prospect, we hit somewhere in the neighborhood of $120,000 to $125,000 a year in overtime costs, although this has been fairly stable across the last 4 years. So overtime is expensive, but not really unchanged. And one of the big reasons for that is all of our personnel have overtime built into their schedules. We don't work a 40-hour week. Each of our people has 8 hours of overtime predictably scheduled into their ambulance shifts. And that creates a stabilizing effect of how much change there is. But to think that it's not expensive would also be incorrect. It just hasn't changed over the years. Our administrative team has done some amazing things. They've dropped the waiting time by 41% since January 1st. They completed one of our scheduled federal audits and found that we met all of our requirements. They were even chosen to participate in a cost tracking system that's going to be used by federal Medicare and Medicaid to design the future of EMS reimbursement. And we were picked, the only one in the state, I might add, to participate in the ET3 pilot, or the Emergency Triage Treatment and Transport pilot, which is done by the Centers for Medicare and Medicaid Innovation. And my favorite one that I added at the end, this came from our third-party billing company, that when they did their assessment, they found that we had set the record for the best overall documentation that they've seen in the last 5 years. So incredible success to our administrative and billing staff on this. So in conclusion, we remain focused on the needs of our staff and have had several improvements across our areas. We've had big wins in training, safety, critical care, equipment, and interdepartmental coordination. We have managed to keep the staffing numbers from falling too much, but it's something that we're going to need to deal with. We have identified that the inadequate compensation is something that we will probably not be successful in staffing if we don't address that. And our billing and budget are on track, although overtime remains quite costly. So, I apologize for the length of this, but it is a complex department with lots of moving parts. So this would have been a busy year for us regardless, with all of the reorganization and projects that we were working on. Plus, there's a virus-y thing going around that has been a bit of a distraction. So, a busy year.
Well, thank you, Dr. Gallagher. A very comprehensive and thorough report. It's really, really helpful for us to understand. Commissioner Cruz has a question.
Thank you, Chairman. When I first started, thank you for being here today. I appreciate this presentation. I just have a couple of questions. When I first started here, I came from a hospice company. We were talking, a lot of folks use 911 services at end of life. And so I wonder, how are you guys working with hospice companies around the county to educate, to reduce 911 calls? That's my question.
Sure. So, it becomes an important part. We have unfortunately seen a decrease in overall hospice utilization affiliated with COVID, which is frustrating. I'm not 100% sure how that plays out, but it continues to be important to us. So our primary interface with them is the ICT-1 team, simply because of the collaboration with the ComCare services. Unfortunately, by the time we get involved with the hospice teams, everybody's in crisis and they've already chosen to abort the hospice process. So while it's important to us, we're downstream of where things tend to fall apart on that. So we don't have a lot of good touch points with hospice care.
I know Malachi was working on a hospice coalition. Are you guys not doing that?
No, he is, and he's still part of it.
Okay.
We're a member at that table, but it's not our show.
Yeah, I just think it would reduce 911 calls if we could get people to understand
Couldn't agree more.
that hospice is a good thing.
Absolutely.
Okay, so page 32, slide 32. It's the one you talk about contractual performance with the hospitals. Can you explain that a little bit? What does that mean?
So our hospital, let me make sure that I'm referencing the same one that you are.
It's page 16 of this, but
Yep, so
number
it's
32.
the green bars. Somebody's scrolling for me.
Yeah.
There it is.
There we go.
Yep. So we have two contracts, one with each of the hospital systems, and it's for their non-emergency transports. So we track how long it takes us to get an ambulance to a facility in order to accomplish their inter-facility transport. Okay. And then we have time metrics associated with both of those. Okay. So this essentially makes them feel comfortable that we're not putting hospital transfers on the back burner to do 911 work. We have to keep them both as priorities.
Okay, gotcha. That answers my question. Okay, so the other thing would be your payments, and so I'd like to talk about write-offs. Do you guys write anything off? How do cash payments compare versus insurance payments?
So I didn't bring that data with me. I have all of that. We do write some things off. We will traditionally try to make at least a single attempt at billing. But if something becomes an uncollectible case, we will write it off. If something we believe is collectible and simply isn't being paid, then we can go to the set-off program. But there are a few things that would be written off. A good example would be as if we have a fatality, a home death, and the estate doesn't have the ability to pay that bill. After a single attempt at collection, we'll write that off.
So if somebody doesn't have insurance and they call for a 911 transport and they go to the hospital and then they get a bill but they don't have insurance, are they billed the full thing that you would bill insurance, that insurance would then write some of it off?
Correct. Same billing for both private pay and insurance. It's one cost.
So if an insurance company gets to write something off, are we not allowing a person who doesn't have insurance to write anything off?
The insurance companies aren't permitted to write anything off
okay,
either.
So they're paying the full
Correct.
amount. Okay. I would like to see that data if you could get that to me.
Oh, yeah.
Okay.
Absolutely.
And then one final question. I've had some folks reach out to me, and when the very first year, I sat down with a group of paramedics, EMTs. Some folks were pretty unhappy, employee morale, other than pay and that kind of thing. So what are you doing as a leader to connect with your staff, to make them feel included, empowered, and what are you doing as a leader to boost morale in your organization?
Sure, absolutely. Well, so several things. So the most visible of it is our employee advisory committee. So we have carved out specific time for them to come and have a voice and work on projects that are important to them. That's where things like the new bags and the shirt change and things like that, that make them feel empowered to tackle the things that might not necessarily be on our list to take on as admin. We all have open door policies. In fact, Paul and I sat with one of our employees last week, or maybe it was the week before, for like an hour and a half, just hearing their input. So open door has been working very well as well. And bothering the county manager until he lets me come and speak to you guys about the issues that are important to the people. So I bet you, well, I don't know, a lot of my staff is watching right now. And hearing
I'm glad you get to answer this question.
hearing their leadership advocate for the things that are important to them is a huge boost to morale. But I'll be honest, I can only challenge so much when they're scared of illness and frustrated at pay issues. Mm-hmm. So we'll continue to do our best, but I probably can't get over those two mountains.
Yeah. You know, every time I see an ambulance drive by, I always think to myself, you know, I respect their position, and I say a little prayer, and hopefully, you know, there is not going to be exposure at the place where they're going. I think this is a really challenging situation. I hope that people understand. I know that the manager mentioned a couple weeks ago, maybe months ago, I don't know, time is escaping me, but talking about we can't have another year where we don't have raises. We have to figure out how to pay our people more, because they're worth a lot more than what they're making or what that we could pay them in the future. So I appreciate you being here. I hope that anybody who is listening, I have an open door as well. A lot of people have reached out to me. So thank you for answering those questions.
Sure, thank you.
Commissioner Dennis.
Thank you, Mr. Chairman. Well, Dr. Gallagher, thank you for being here, and thank you for the update. I appreciate that. Just a couple questions. Right after we got the contract with the city of Wichita going, I used to get the updates periodically on how we're doing. Today is the first time I've gotten an update for some time, and I see that it looks like we're doing very well. Just one quarter we dropped down below what our contract requirement was with the city of Wichita, but it's still very good, even where that was. So I don't need anything formal. Just kind of every once in a while let me know how that contract's going, because if you recall, we worked very hard to get that contract moving, and I want to make sure that we live up to what we promised the city of Wichita. So just give me a little heads up every once in a while. We are creating the new paramedic position out at Cheney and Clearwater, and I understand that the new paramedic position is in Clearwater. I'm just wondering if we got an update on when we'll be able to put the one in Cheney.
So the only update that we have is that Fleet believes that the vehicles will be available at the beginning of next month. So we have all of the other pieces in place.
Very good.
So once we have the vehicles, we'll be able to roll them.
And just be clear, we still have an ambulance sitting out at Garden Plain while we're waiting for the paramedic to get into Cheney. So we're still providing the same level of service out in that area.
That is correct.
Very good. One group that I also sit on, from my background in education, is I sit on a career and tech ed advisory group for the Kansas State Board of Education. And just met here a week or so ago, and one of the things that I brought up to them was staffing for EMTs and what they can do to help us out in that area. So if you've got any ideas of what we can get the career and tech ed folks to do to help us with your staffing, I'd be happy to take that back to the Kansas State Board of Education and pass that along to them.
Sure, that's helpful. I appreciate the offer. And while I certainly wouldn't turn away any improvement in the supply, I need to stop my losses. I need the people that we currently have to stay as opposed to leaving. So not to take away from the supply chain at all, but we have a drain issue, not a faucet issue.
I agree. As a trained person that has been with us for a while, has a lot of experience that we got to continue to retain. So I appreciate that. But if there's anything that we can do there, and the final thing that I have is I've been an advocate for helping find a way that we can increase the pay for some time, and I'll continue to do that. I certainly hope that we can identify some method that we can give pay raises to all of our folks in EMS. I saw that we had like a $500,000 increase in what our receipts were, and I don't know how that we can fold some of that back into doing some kind of pay raises for our folks that are paramedics and EMTs. So that's something that we need to think about in the future, but I definitely support any kind of ideas that you could come up with to help us with that. So, thank you, Mr. Chairman. I appreciate it.
Very good. Commissioner Howell.
Thank you. I have a few questions. Appreciate you being here. There are some good things in the report. I do have a few questions about some of the things that aren't quite clear to me. So let me go through this a little bit here. Looking at slide on page 11, slide 22. You show 3 categories there, and for example, EMS, EMT to firefighter EMT. The left category there, that small blue bar, what does that represent?
The far left, that's
For each one of the 6 categories.
that's the pay for the EMS department. The middle bar is Sedgwick County Fire District number 1, and the dark red bar is City of Wichita Fire Department. So it's EMS, fire, and fire.
Okay. All right, that helps.
Yeah, sorry about this. So the frustration here is there isn't a single rank level at either the minimum, the midpoint, or the maximum where EMS is anywhere other than dead last. And it's been frustrating from a onboarding standpoint because in order to hire on as a paramedic with us, the applicant has to successfully complete a 2-year paramedic program at their own cost, which we've calculated out to be about $40,000 when you combine the tuition costs and the lost wages of the time in school. And after they've endured that $40,000 cost, we then bring them into public safety and pay them at the lowest level. In contrast, when we bring on a firefighter, we bring them on, we invest in their training as a firefighter and then pay them more. So the paramedic carries their own cost to get paid less. The fire department is provided their education and is paid more.
Yeah, in fact, I was going to get into that in just a moment. In fact, we have LATC does the same thing for our commissioned officers. They go through that training. Even our detention deputies also go through our own training. They can come off the street with actually no training, and we give them, if you will, paid training to get to that point where they're being certified for Sedgwick County. Whereas our paramedics and EMTs for EMS, I guess we validate them through certifications. We certified them under the OMD, Office of the OMD.
Yeah, we make them take tests.
We recognize their outside training. Okay. Thank you for that question answer. Let's go over to slide 25 on page 13. This one stands out to me quite a bit. For example, on the team, let's see here, get this right.
Crew leader?
The crew leader, for example, we've lost 11. This year's only 75% complete. We still have a quarter left to go. But we've lost 11. In the last 4 years, we've lost 11 total. So something's happened in 2020 that is different. And on the paramedic, we've lost 19. That's what it says on this slide, but I have noticed, if you go over here to the next slide on slide 20, on slide 28, it says we've lost 30 paramedics.
So,
And I'm looking also, if you go to slide 23, it says we have a total of 68 positions for paramedic and 38 crew leaders. So if you do the calculation there, we've lost 56%. Take that back. We lost 44% of our paramedics in 1 year, and 75, again, in 9 months of 1 year. 44% of our paramedics have been swapped out. And we've lost 29% of our crew leaders. I'm concerned about that. So what is causing that to happen?
So the red bar of paramedics and the orange bar of crew leaders, those are both paramedics. One is a higher rank level that supervises on an ambulance.
Okay.
So, but they are all paramedics.
Okay, that helps.
So no, it's been a terrible year. People do not want to work in public safety this year. And by no means am I trying to blame this all on COVID. I don't think that that's the entire cause of it. I think we naturally see an increase in separations across any reorganization. When we went back and looked at the previous reorganization, we actually saw a comparable size loss rate. So I think between that with COVID and the growing frustrations around compensation, we have a very uphill battle to fight.
Well, normally, retention is more difficult when unemployment is low. We have a very high unemployment right now in Sedgwick County, and really in the state of Kansas. We're record level high numbers right now. Mm-hmm. Things are getting better, but it's not a great time to change jobs.
Correct,
So
and
it's
impossible.
really curious to me that this is the time we're seeing people leave. And to me, it's very concerning when you have got 44% of your of a particular part of your staff have, again, maybe I've, make sure I look at this again correctly. So 30 would be out of the 68, or 30 would be out of how many positions?
The 30 would be out of how many? Is that what you're asking?
How many positions do we have total?
So we have 140 frontline positions, FTEs, that can be
we
filled.
lost how many total?
And we've lost 32.
32 out of 140 just this year.
Correct.
Okay. My math needs to be corrected then. Anyway, still concerning.
It is. And to the unemployment issue, you would think that this is a place where people would be coming in, but when they're up against a 2-year requirement to become certified, they don't have the ability to do so without a 2-year forward-thinking plan.
Well, again, so I would just, I would highlight this. They're not going to go from doing Sedgwick County EMS to something that's unrelated to their training. Most of the time, they're going to find another position somewhere else.
Correct.
So there's other places, whether it be Mulvane or Johnson County or wherever they would go, they're going to find a position theoretically, probably in their career field that they've chosen. They're not going to give up on their training. They've invested too much in their career for them to walk away from that. So
correct.
This is
So Mulvane is paying almost $3 an hour more. We've lost several to that service. We've got several that have gone to freestanding cardiac catheterization hospitals that are paying $2.50 to $3 an hour more. And these guys are offering a lower workload, less exposure, and a higher pay rate. And no, I haven't been able to compete with that.
Let's talk about slide 29 a little bit. You talk about averages, and we're up close to 8 minutes. At the top of that line, there's about 8 minutes. Is that not our goal, is 8 minutes for Sedgwick County? So we're just barely under our established goal of 8 minutes for response time. Is that
9 minutes, 8 minutes and
9
59
minutes?
seconds.
Okay, so we're about a minute less than our goal.
Correct.
I would like to know what the highs and lows are, because averages kind of hide the truth here. I'd like to know what the highs and lows are. Otherwise, I'd like to actually see the data rather than simply see an average calculation, because I think it might reveal other things that maybe ought to be understood here. For example, if you're dispatching an ambulance from Goddard to Derby, for example, we would need to know that response time is going to be nowhere near 8 minutes. It would be 20 minutes if that happened. I'm not saying it did, but let's just say that may be what we have to do, because maybe the only ambulance available. We have a very large county. If the only ambulance available is in the other side of the county, and you've got to go from one side of the county clear to the other, your response time is not going to be anywhere near 8 minutes. It might be 15 to 20 minutes.
Correct.
So I'd like to see what that number is, because I think it's indicative of what may be really going on here. And same thing. So I'm curious about the lights and siren. If we have an EMS call, you said something has changed. We're not using lights and sirens as much.
Correct. So
what happened?
Well, it's not what happened. It's the system design. So years ago, we implemented the emergency medical dispatch system in partnership with Director Forshee and started characterizing which resources should be sent to which calls and with what level of priority. So you may recall there were 9 priorities created, ranging from the most critical of not breathing all the way to routine interfacility transfers. And each one of those was assigned what apparatus should go to it, whether this is a fire-only call, whether this is an EMS-only call, or a combined call, and then whether those apparatus should travel lights and siren or regular traffic. So that was an improvement in our efficiencies of decreasing the use of inappropriate lights and siren. But the natural effect of that is all of those calls that should have always been non-emergent artificially raise your response times because you're now following all of the traffic laws. So it wouldn't be right to think of that as a bad trend. It's an intentional trend that we've designed.
Okay. Do we track how much time the staff are actually out on calls versus time in their post waiting for the next call? Do we track that?
Kind of. So we have the ability to track the time from which they're dispatched on a call until the time that they become re-available for dispatch. The trouble with that is it doesn't incorporate any of the other tasks that they're required to do, documentation, driving back to the post, any of the other things that they do that are related to that call. So I realize it's not a great answer, but the answer is kind of. We can track a portion of it, but not the soft portion of it.
Okay. You talk about zero status, or status zero. Mm-hmm. I asked a question to manager. How often does that happen? I mean, I hope it never happens, but I understand it does happen once in a while because we can't control when calls come in, and sometimes you just get a rush of calls for some reason.
Correct.
And so it happens. But so based on our goal of not having that happen, how many times does it happen? Can we quantify that in terms of how many days per year, or how many times this year has it happened since January 1st? Can we talk about that?
Sure. I agree with you. And in fact, that's something I wish we could track. Unfortunately, due to the limitations of our current CAD system, there isn't any way for us to pull those out of the system. The closest surrogate that we have is the administrative pager list. So oftentimes, but with poor reliability, the dispatcher will enter a call into the paging system to let the supervisors know that we have a status zero event. The trouble with that is those only happen during the busiest portions, and so the miss rate, or they were overwhelmed or forgot to send out a page, is expected to be high. So we do not have data on that. Not only for EMS, we also don't have it for fire or police. It just doesn't exist in our system.
Okay, I think that's something we need to try to solve that, because I think we need to know that number. I think it's a very important number to track. I understand it has happened quite a lot this year. I mean, I'm hearing from people who work in the field saying, yeah, we're back to zero status again today. It happened for maybe just been 5 minutes, but it happened.
Well, and in fact, most of them are only for seconds. So the dispatchers will put out that it's a status zero situation, and usually within the first 5 or 10 seconds, one of the ambulances that is at a hospital will clear because they hear that on the radio, and the status zero event ends within moments.
On slide 38, it talks about the when you don't have an ambulance available at a station. So again, I understand that is 100% here the design of our system. We would like to see a vehicle, crew vehicle, and a crew available at that station. So 100% would represent our design.
That is the staffing table. So that would represent what we could pull off if we had zero vacancies, no vacation, no sick time, no anything else. That would be everyone comes to work every day without fail.
But do we not plan for vacation and sick leave in our system? So we need to overstaff just a little bit to anticipate that. So we still need to have ambulances and crews in those stations.
We should. We would take any FTEs you'd give us. We are currently not overstaffed sufficiently to meet any targets.
I guess I would just say I would think 100% says we've met our design. We've met our design of our organization. That these crews and vehicles are placed in the stations where we want them, and they may be out on a call, but they're still assigned to that post. They showed up today. They're taking a call, but they're there. They're available to do the work by design. Now, some posts sometimes I guess there's hours of the day where some posts are designed not to have an active crew, and that would still be 100% because it still fits our design.
Correct.
Okay, so this represents, if you will, a shortfall from what our design of those vehicles and crews being placed in those posts.
This represents the staffing table.
Okay.
So I don't know if you'll recall when we reported out on the staffing situation about 8 or 9 months ago, and we presented to you that we're 22 FTEs short of maintaining the full design. That would get us to flat 100%, accounting for illness, injury, vacation, all of those things. So we are a far cry from staffed to hit 100% bars. Now, I could have presented this data to you for what our actual, we could pull it off staffing levels would, but that would have overstated how much we had put out in production. So I gave you the dimmest view.
I can tell my colleagues are getting tired of me asking a question. My last question for now, maybe I'll think of more in a minute, but the geographic map on slide 42. We in the past have touted the idea that we anticipate the next call. We stage those ambulances where we think the next call is going to happen. I assume that still happens. So now we've placed a couple of crews and vehicles out in western Sedgwick County. Are they waiting for the next call, or where they are stationed, or are they back to the city, anticipating the call in the city? Because that's where the next call is likely to happen in the city of Wichita. So that's where most of the calls happen. Are they waiting out by Cheney for a call, or Clearwater, or are they, if you will, closer to the city, waiting for a call, especially when we're down to just maybe a couple of vehicles available? They're not going to be out there in western Sedgwick County waiting for a call. They're going to be staged, if you will, closer to the city. Is that correct?
Are you asking about the ambulances or the quick response vehicles, the Suburbans?
The ambulances, I guess.
The ambulances move towards the core as needed. The quick response vehicles do not. So there's an ambulance stationed far west. If the system status goes down, that truck will be pulled eastward.
But we do have a captain or someone who's a paramedic is staged in western Sedgwick County waiting for a call, and they're not going to be staged. They're going to be they're back to the Suburban then, I guess.
So the Suburban
they're waiting there.
The Suburbans stay in their area. Now, if they happen to be the closest to a call that's happening, they will be dispatched.
Does that add to the shortfall of staffing we have elsewhere in the county? So it leaves us, if you will, short for crews elsewhere in the county?
It does.
That's a problem. Thank you.
Commissioner Dennis?
Thank you, Mr. Chairman. To follow up on some of Commissioner Howell's questions, and especially so the public that's watching, I want them to be clear on how that our system operates. So if you can go into detail a little bit, our system is looking at who we can get to the person that needs the aid the quickest, and that may be a fire. And the transport is something that we need to worry about after we get the person stabilized. So if you can kind of detail, because I think that the response times and so forth, the charts and the heat map and so forth, don't really bring out how your system is really designed to operate. So if you can please let the public understand that.
No, absolutely. It's super complex. I mean, the amount of detail here is overwhelming. This is why I have you until 2 p.m. So, so we are known in EMS as a transport agency. It's what we were born as. We were a ride to a hospital, and that is what we still are in many people's minds. However, over the last several decades, we have evolved into being part of the healthcare system, and we provide far more than the transport to the hospital. While we still, of course, do that, it has fallen down the levels of the value that we add to the patient. So, in fact, with the complexities of what paramedics can do now, transport is oftentimes not the time-sensitive component of what we need, right? So the example that I often cite is your child or grandchild falls off the monkey bars and breaks their arm. The timeliness of that child getting to the hospital is essentially none. right? You're going to be taken there, you're going to get checked into the ER, they're going to take an x-ray, they're going to call the orthopedist. It's going to be hours, and you might get a surgery or a cast or a splint later that day or the following day. But the part of that that's time sensitive is that your child is suffering. So getting to that person with somebody who can provide pain medicine, that's the time sensitive component of that care. No transport involved in the timeliness. Do they need to go to the hospital? Absolutely, but it's not the time focus, okay? On the other end of the spectrum, the biggest, scariest calls that we run are the not breathing cardiac arrest. We don't even transport those patients many of the time because we can deliver hospital level of care in the person's kitchen or living room. So getting the personnel with the equipment and the knowledge and the skill to the bedside is what our system excels at. We also have a transport function that is secondary to our providers' medical care.
Very good. And this response time charts that you have are really response time to get the transport there, and other aid is very likely there to do the emergency need on that patient if they need to be taken care of immediately, as you described.
Correct. Our fire-based first responders are almost exclusively on scene before us and can initiate life-saving measures.
Okay, very good. And just to be clear, we didn't increase staffing or do any other action that's going to detract from this heat map that you've got up there by placing those paramedics out in Cheney and in Clearwater, correct?
You lost me. Try one more time.
Okay. We had an ambulance, or we still do have an ambulance at Garden Plain.
Correct.
Those our ambulance are staffed with 2 paramedics.
Correct.
We'll to be taking one of those paramedics and putting them in Cheney and one of those paramedics and putting them in Clearwater. So we have not affected the total staffing by accomplishing that. What we've done is we put a first responder that can take care of those life-saving measures that you just mentioned and get to the patient quicker, and the transport is not as critical as getting someone there that's qualified that can help that individual out, correct?
That is all correct.
Very good.
The hard part is currently we're running the ambulance out there and we're running the Clearwater program. So I had a little bit more I had to put in the cup because it went to 3 people.
Yeah, and we need to get that second vehicle configured as quickly as possible so we can get back to the point where we were trying to get when we were designing this.
Paul and I both surrendered our vehicles to keep this thing moving, so we'll get it done as fast as we can.
Very good. Thank you, Dr. Gallagher.
Commissioner O'Donnell?
Thank you. Dr. Gallagher, thanks for the overview today. It's very good information for us to have. 2 points that 2 of my colleagues said. I agree with what Commissioner Cruz said earlier, that ever since COVID, when I do see those ambulances, it does make me more nervous thinking of just the community outbreak of the coronavirus, about how much these men and women are putting their lives on the line and their health every single day. And then what Commissioner Dennis was talking about earlier with some of the funding that we might have with it appears that we have a little bit of surplus. I think I'd like to talk to the manager, see what we can do, because that pay disparity is pretty shocking. And right now, more than ever, I think the people in your department really do need some type of a morale boost. And I know we've really said no new raises this year. I mean, our budget, we're just trying to get by, but if there are ways for us to do it, and if you have some creative suggestions as well, feel free to reach out to me or any of us, because we do need to do something more for our EMS here in Sedgwick County, because really at the end of the day, the most important government functions that we can do is when someone calls 911, they're going to have people show up to their house. So I don't think there's anything more essential than having our 911 call center and sending an ambulance out to someone's house. So I want to make sure that we can support your people and our people. So thank you, John, for this.
Thank you.
Okay. Thank you, John. Dr. Gallagher, appreciate, again, what's that?
That's it. I got 2 more hours.
Yeah, well, we have a few things we got to get accomplished as well. So.
Very good. Thank you all.
Anyway, thank you again for the questions and all the work you're doing. Please thank your crew and all your departments for what they've been doing this year and working through these troubled times. So thank
Very
you
good.
again. All right. Okay.
That's all we had today, sir, for presentation. Adrian is here, Tim is here. If there's any COVID questions, we could answer them, but we didn't really have anything to present, so
Okay.
up to you guys now.
Well, we're going to get a CARES and COVID update tomorrow as well, a little bit? Okay. Does anybody got any questions?
No, I just want to say I'm glad that everybody's back in the office. I'm glad that you guys are feeling better. I hope that you're feeling better.
I am feeling better. And 3 of us in this room are the safest people in this room right now because we have antibodies. But thank you for that, Commissioner.
Glad to see you guys back.
Okay. Thank you, Tom. Then we will adjourn, and we will have our regular meeting tomorrow, Wednesday. Thank you.